A very warm welcome on behalf of the Council of the IUSSP, the Worldwide Association of Population Scientists. It's really great that you are joining this webinar on social inequalities and multi-morbidity at death. For those who are new to IUSSP, this webinar is organized by one of our scientific panels, who are actually the core of the scientific body of the IUSSP. And if you are new to IUSSP, we hope, of course, that following this webinar will convince you to join us and join our community. I can assure you there are lots of advantages. And one of those is a reduced registration fee for the upcoming International Population Conference of 2025 in Brisbane, Australia. And as you may know, these are, of course, the Olympics of demography, so you really should be there. But without further ado, we have a great program today, thanks to our panel. And I'd like to pass on the floor to Aline. Aline, let's get started.
Thank you, Nico. Thank you very much. So everybody, so thank you for attending this webinar. So as far as I know, there are about 200 people who are registered to this webinar. So I don't know how many will attend, but that's great. And thank you to our two speakers. So Tim Adair from the University of Melbourne and Paul Peters from Carleton University in Canada. So both of you will present results of research focusing on social inequalities in multi-morbidity at death. Just a few words about the organization of this webinar. So our two speakers will have around 30 minutes each to present their research. After each talk, Sergi Trias will take a first round of questions in the chat. So we would like to keep around 15 minutes at the end of the two talk to take questions that maybe require a longer response. So if you want to ask questions, please use the chat. You can do it during the talk or after the talk, it doesn't matter. And please indicate to whom your question is addressed, if it's a question at the end of the two talks. So Tim, the floor is yours now.
Okay, thank you, Aileen. I'll just please let me share my screen. Okay, hello everyone. I trust you can see my screen okay. Thank you for the opportunity to talk to you today. I will be presenting on the topic using data from Australia, so census-linked multiple cause of death data. Just to start with, I'll give a bit of background of some recent trends in mortality in Australia. So we have seen, certainly in the pre-COVID period, a slowdown in premature mortality rate decline. So there had been a long-term decline in premature mortality rates, so that's mortality from 35 to 74 years, but that has been declining in more recent years. And this has been accompanied by widening area-level socio-economic inequalities. And so this chart here is from a paper I published a few years ago. The red line shows the ratio of premature mortality rates, age standardized, for the lowest quintile of area based on an area level socioeconomic index from 2011 to 2016. And you can see that red line has been increasing. So the ratio of the lowest to the highest quintile in terms of the mortality rates has been increasing. And in fact, there's actually been a stagnation in premature mortality rates in this lowest area level socioeconomic quintile. So that's one part of the background. Another part of the background is that there have been fairly adverse trends in premature cardiovascular disease mortality from what we call cardiometabolic conditions. So these are conditions for which there's a major risk factor of overweight and especially obesity. And it's just specifically what it is. It's measured as any cardiovascular disease reported in part 1 or part 2 of the death certificate with one or more of diabetes, chronic kidney disease, obesity, lipidemias or high cholesterol, or hypertensive heart disease. And the acronym used for this group of conditions is DKOLH-CVD or DKOL-CVD. And so some research I published back in 2020, I think it was, has shown that in this chart here on the right, the green and red lines show the cardiovascular or the cardiometabolic conditions related to overweight and obesity have actually had a positive annual percentage change in 2014, 15 and 16, well, certainly for males anyway. And so basically that means that we've had an increase in mortality, premature mortality rates from those conditions and that was measured using multiple cause of death data. And also Australia, excuse me, I just went a bit farther. Australia in recent years has not ranked very well at all amongst high income countries in substance use disorder mortality rates. So this is a table by age group showing Australia's ranking in alcohol and drug mortality rates amongst 24 high income countries, not including the US, which is clearly has the highest rates of the high income countries. And this is for age groups 25 to 64 years. And you can see here that in the 40 to 44 age group, for example, for females, Australia is ranked 24th of 24 countries, and not well at all in terms of its ranking. And even in the age groups for males, where it's has its best ranking, it's still only 12th out of 24. So it's one of the worst ranked countries in drug and alcohol mortality rates. So what I'd like to do today is to look at some of these patterns in a bit more detail, in particular looking at inequalities in some of these clusters of comorbidities using Australian death registration data that are now linked to census data to improve our understanding of these patterns. So the Australian Bureau of Statistics in the last few years has developed a multi-agency data integration project, or MADIP. It's a very large project. It involves integration of a whole range of data sets from various government departments. This sort of work has been undertaken in other countries by their statistical agencies. And so for the purposes of this study, we have death registration data that can be linked at the individual level to census data. So death registration data contains all reported conditions on the death certificate, or multiple causes of death, while census data, of course, contain detailed information on socio-economic characteristics of individuals, of households, and also geographic areas. So previously, we could really only link or analyze death registration data by area level socioeconomic characteristics, like I presented earlier. Now we can look at households and also individuals in terms of inequalities. And so these data allow us to better understand recent trends and patterns in mortality within Australia. And especially though, looking at inequalities in premature mortality from these clusters of comorbidities in which Australia is not faring particularly well amongst comparable countries. So specifically, cardiovascular diseases related to overweight and obesity, and also alcohol and drug related mortality. So just looking at some of the previous research on that has used some of the MADIP data. So there has been some findings that inequalities between the highest and lowest level of education in terms of all-cause mortality from 25 to 84 years of so rate ratios of 2.2 for males and 1.64 for females, so the lowest versus the highest level of education, and differences in life expectancy at age 25 years of 9.1 years for males and 5.5 years for females, again, between the lowest and highest level of education. Now, in terms of multi-morbidities, there's quite detailed literature showing there's a higher risk of multi-morbidities in Australia and other high-income countries amongst lower socioeconomic groups. So it can be hypothesized that we would see fairly wide wider inequalities in mortality risk or mortality rates between in terms of multi-morbidities compared to, say, single causes of death. Now, looking at particular risk factors, in Australia, prevalence of overweight and obesity is higher amongst lower socioeconomic groups and also outside of major cities. And also alcohol-related mortality and consumption is higher amongst lower socioeconomic groups, generally reflecting greater alcohol consumption amongst these groups. And also drug-related mortality, what we know of it, also exhibits significant socioeconomic inequalities. So based on the literature and some of these more adverse trends in mortality in Australia that we're seeing, I think we can expect there would be reasonably significant inequalities in some of these comorbidities, but we'd like to explore this further with the data. So the aims of the presentation are to measure socioeconomic inequalities in premature mortality from 25 to 74 years in Australia from comorbidity clusters of cardiovascular disease mortality and alcohol and drug-related mortality. Okay, so the data, the Australian Bureau of Statistics Multi-Agency Data Integration Project, it comprises data sets from a whole range of government agencies, statistics, health, taxation, etc. And the data are linked using what is called a person linkage spine. So the person linkage spine aims to identify all individuals who are living in Australia at any point in time based on their Medicare, so healthcare card, Centrelink, which is government payment system, and also income tax data. It's a fairly secure sort of project, so it's very detailed data, but only approved projects can, only users who are on approved projects can actually use the data, and we can only access the data in a very secure environment, and all data outputs must be approved by the ABS. So all the outputs I'm showing you today have been approved by the Bureau of Statistics. Okay, so the data we're looking at here are death registration data, including multiple causes of death from 2016 to 19, and also 2016 census data. So these are linked together, meaning that we have a census that was conducted in August of 2016, and we are looking at deaths of that occurred after the night of the census. And so effectively what we have is people who were alive at the time of the census, and then we have deaths. So those who died subsequent to the census, we have a death registration for them. Or certainly for most of them anyway, almost all of them. So just to describe some of the linkage rates. So we have at the top a personal linkage spine. Okay. And it is linked to death registrations from August 2016 to 2019. So these are effectively our multiple causes of death data. And it is also linked, the personal linkage spine, to the 2016 census, which was conducted in August of that year, which has our individual household and geographic socioeconomic information. The death registrations, 98.8% of them match to the spine, so very good linkage rate. The census is not so high. Around 89% of census cases match to the linkage spine, but it's still not too bad. There was, or there is, the 2011 census, which can be linked in the same way, but the linkage rate for the 2011 census was less than 80%. So I haven't used that. I've used the stronger linkage rates we have for the 2016 census. Now, in terms of causes of death, so for cardiovascular disease mortality, I will be using this cluster of cardiometabolic conditions, the DCOL CVD I described earlier. These are the ICD-10 codes. It excludes cardiac arrest, but it includes diabetes, chronic kidney, obesity, lipidemias, or hypertension. And so these conditions have a common risk factor of overweight and obesity. I'm also using other CVD, other cardiovascular diseases, which is all other deaths where a cardiovascular disease was reported on the death certificate. And I'm also looking specifically at where obesity was reported on the death certificate. Obesity is underreported on death certificates, but an advantage of analysing obesity itself is that it is very clearly someone who died who had obesity as a significant associated cause of death. So even though we recognise there is underreporting of obesity, it's still worthwhile to analyse. Now, for the alcohol-related causes of death, this includes cirrhosis of the liver and other liver diseases, alcohol-related disorders, so alcohol use, abuse, and dependence, and also intentional self-poisoning, accidental poisoning, or death by undetermined intent with by and exposure to alcohol. Similarly, for drug-related mortality, we've got drug-related disorders and intentional self-poisoning, accidental poisoning, and undetermined intent by an exposure to drugs. And then finally, I'll look at both people who died with both alcohol and drug-related causes reported on their death certificate. And around 36% of drug-related deaths also have an alcohol-related cause. So they do occur together quite frequently. And we're interested to see whether inequalities for those who died of both alcohol and drug-related causes are any different to those who died from one or the other. Socioeconomic variables, we have household income, which is equivalized, approximately quintiles of that. We have an area level index of relative socioeconomic advantage and disadvantage, which is measured at quite a small level, only an average population of 400. There is highest educational attainment, labour force status, and for those not in the labour force, I have excluded those who need assistance for a health or for disability or a health condition, and also excluded those who are caring for children. So trying to find those who are out of the labour force, but for reasons other than health or caregiving. And also looking at marital status and also lone person households, which can be maybe give us some insights into social isolation. Okay, so in terms of the methods, so analysing deaths from the 10th of August 2016 to 31st of December 2019 of people aged 25 to 74 years who are living in Australia on the census night. I excluded COVID-19 pandemic years, partly because I think an analysis of those years is worthy of its own study, and I wanted to focus on CVDs and these drug and alcohol related causes. The denominator is person years lived during this period by people who were included in the 2016 census. Okay, I've excluded visitors, and I've calculated cause-specific age standardised death rates, standardised to the 2016 census population with 95% confidence intervals, assuming a Poisson distribution of deaths. And I've calculated ratios of those age standardised death rates between different socioeconomic groups and conducted Cox regression of cause-specific deaths with a range of covariates. I won't be showing all the Cox regression results just for a couple of the causes of death, but I've controlled for household tenure and English language being spoken at home, Indigenous status, migrant status, and state and territory and major city. So there's also an issue where just over 10% of census cases are not linked to the spine, and the unlinked cases are more likely to come from poorer socioeconomic groups. And so ignoring them would bias our results. And so to try and overcome this issue, I conducted a negative binomial regression of the cause-specific mortality of the linked cases, offset by the log of person years, using socioeconomic and geographic covariates, and then use the coefficients to predict cause-specific deaths for the census cases not linked to the spine. Okay, so it's a way of estimating deaths for the census cases not linked to the spine. And then effectively you have those predicted deaths for each combination of our covariates, and then we can then take the predicted cause-specific deaths for each covariate and by age and sex, and sum them to the actual deaths for each of those same covariates and age groups, and for males and females. So it's a way of trying to overcome that bias of that we have 10% or so of census cases not linked to the spine. Okay, so on to our results. Firstly, this is an example of how frequently these cardiometabolic conditions are reported together. And so how to read this table is we have conditions. So we have six conditions or groups of conditions in the rows. Diabetes is the first one. And so this figure here of 19.8% for chronic kidney means that of all the deaths with diabetes reported on the death certificate, 20% of them have chronic kidney disease reported, and 10% have obesity, 12% lipidemias, 42% hypertension. And so you can see here that diabetes and hypertension are the two most commonly reported. Obesity tends to be fairly low because it's not reported all that often. And yeah, as I said, it tends to be underreported. And for this decol CVD group, which is the reporting of any of these conditions with the cardiovascular disease, it's 48% of those have diabetes reported, 21% chronic kidney, 13% obesity, 15% lipidemias, and 57% hypertension. Okay, so on to some of the results. So this is comparing, you can see down the bottom here, we have decol CVD in red, so our cardiometabolic conditions. In blue, we have other CVD, and in the orange color, we have obesity. And we have, firstly at the top, we have household income, and we're comparing a reference category of the highest income, and approximately these are quintiles. What we have here are the ratios of age standardized death rates. So just to interpret, for obesity, someone who has obesity reported on the death certificate, if they are in the lowest household income quintile, their age standardized death rate is around 5 to 6 times higher than someone in the highest income quintile, household income quintile. For decol CVD, for the cardiometabolic conditions, it's around 4 times. And for other cardiovascular diseases in blue, it's around a bit over 3 times. And so this pattern, basically we seem to be seeing that the lower your household income and the lower your level of education, the higher your ratio of death rates is compared to the highest education or highest income. And these ratios tend to be wider for people, for deaths from obesity itself, as well as deaths from the cardiometabolic conditions compared to other cardiovascular diseases. And you can see here that certainly the obesity is much wider, has much wider inequalities than these other cardiovascular conditions, both for males and females for income, and also for education as well. So this now is the results of the Cox regression. So these are showing hazard ratios, and these are controlling for other factors which may be explaining the reasons we have these household income inequalities and also education inequalities. And so the hazard ratios are now a bit over two times higher for household income for decol CVD, and for education, yeah, a touch over 2. But again, we've got them slightly higher for the cardiometabolic conditions compared with other CVDs. And a similar pattern is found also over here for females. I didn't include obesity here because obesity has fairly low death rates, and there were some issues with running the Cox regression on a pretty low outcome variable. Moving now on to area level socioeconomic status and labour force status. Again, it's a similar pattern where for area level socioeconomic status, obesity has the widest inequalities, especially I think for females, which could reflect that it's not just an individual level issue with obesity inequalities, but there could be some area level factors playing a role as well. And again, the cardiometabolic conditions, which are indirectly related to, for which we have a major risk factor is overweight and obesity, they have wider inequalities than for the CVD. So I've gone back here, sorry, these are rate ratios again. These are not the Cox regression results. And at the bottom, we have labour force status, and we have here employed, then unemployed, and then not in the labour force. And again, obesity, quite wide inequalities in the ratio of mortality rates for those not in the labour force to those who are employed, around 5 times higher for both males and females. And again, the cardiometabolic conditions are next widest ratios, and other CVD, the narrower ratios. And just moving on to marital status, we have never married or not de facto, or never been in a de facto relationship at the top, and at the bottom we have our reference categories married or de facto. Again, obesity, the wider inequalities. So if you've never married or not in a de facto relationship, risk of, or the rate rather of mortality with obesity reported on a death certificate is around 5 times higher for men and about 4 times higher for women. Same again for lone households, not as great a difference, but again, the ratio for obesity is higher than for the other CVDs. There's also a bit of, for those who are widowed, there's a higher rate ratio, perhaps indicative of some clustering of some of these conditions as well within families. Okay, I'll move on now on to drug and alcohol related mortality. Again, this is like the first chart I showed for the cardiovascular diseases. We have rate ratios for household income. And so we have, in blue, we have alcohol, red, we have drug related, and the orange is alcohol and drug related mortality. And we have quite wide inequalities here. So by income, for the lowest income bracket, we have differences for each of them around the sort of, 5 to 7 times higher than for the highest household income. And for education, and that's the case for both males and females. But for education, it is much, for men anyway, it's much wider for drug and alcohol and drug-related mortality together than it is for the blue and for alcohol-related mortality. But it's interesting that for education, we're looking at rate ratios around 9 or 10 times higher for men for both drug-related mortality and drug and alcohol-related mortality. And again, these seem to go down a gradient as expected from the lowest level of education to the highest. But yeah, these seem to, certainly for men, seem to show a wider level of inequalities than for women by education anyway. More similar for household income. And so when we look at these are now the Cox regression results, so controlling for other socio-economic and geographic factors. The hazard ratio reduces somewhat. So for household income, the lowest bracket, it gets down to about 2.5 for both males and females, or a bit under 3. While for highest educational attainment, drug is fairly high for men, around 4 times, or a hazard ratio of around 4, while for alcohol it's around 2. I didn't include drug and alcohol related mortality here because, again, it was a fairly had a fairly low proportion of all the population who actually died from those conditions. So I had some issues running the Cox regression for it. And so by education for females, it's around for drugs, it's a drug-related mortality, a bit over a hazard ratio of a bit over 2 in these lowest education brackets, and a little bit under 2 for alcohol. Just moving on to some of the other analyses, we have here area level socioeconomic advantage. It's got a much lower rate. These are the age standardized rate ratios. They're much lower compared to the individual level measurements. So around 3 for each of them for males, and for females again around 3 times. If you go back to the previous slide, the 2 slides earlier, for household income and education, we were looking at, well over 6 or 7 or 8 or 9 times higher. So perhaps these area level factors are less of an influence perhaps for the alcohol and drug related mortality compared to individual level characteristics, which is, I mean, I don't have a sort of a reason why that may be the case, but I'd be interested if anyone had had seen similar results elsewhere or had some explanation. And then we have labour force status. So very, very wide inequalities for those not in the labour force. So for, we're looking actually at 15 times higher for men for drug and alcohol combined, and women probably around 10 or even 14 for drugs, and alcohol around 6 or 7 or 8 or so. I mean, this could be some reverse causality. So even though I tried to exclude those who needed assistance for health or disability issues, it could be that those who have had issues with drug use, who are not in the labour force, and rather than, and so that's the reason why we have these high rate ratios rather than anything intrinsic to not being in the labour force being the main reason for dying of drug-related mortality. And now looking at marital status, so those sort of never married compared to those married, especially for drug-related and drug and alcohol-related mortality, we've got rate ratios around 6-7 times higher for men and around 8 or 9 times higher for women, and lone person households around 4 or 5 times higher. So, again, maybe there's some reverse causality going on, but yeah, it's interesting that some of these indicators, proxy indicators of social isolation, may indicate are leading to, associated with high levels of mortality from alcohol and drug, and especially drug-related mortality. Okay, so they're the results. I maybe went through them a little bit quickly, but there's quite a lot to unpack. Certainly, I think what this analysis has shown is we've got substantial inequalities in premature mortality from clusters of comorbidities in Australia. For the cardiometabolic conditions, decol CVD, that are related to overweight and obesity, these have wider inequalities than other CVD mortality. And this is consistent with literature that obesity is higher in low socioeconomic groups, but I think this is good it's a good set of data to actually demonstrate what the impact is on mortality. And that's not something we necessarily knew before, that those who are dying from cardiometabolic conditions or from obesity itself have wider inequalities than for other causes of death related to cardiovascular diseases. And so we're looking at rate ratios often exceeding 3 or even exceeding 5 for obesity. And these inequalities are concerning given that premature mortality rates in Australia from these cardiometabolic conditions have been increasing, as they have been in other countries as well. The inequalities for alcohol and drug-related mortality are wider than for cardiovascular diseases. And these, the alcohol and drug-related mortality combined has higher inequalities than just for alcohol-related mortality. And we're looking at very, very substantial differences at the bivariate, looking at the bivariate association, but even with the multivariate analyses, we're looking at hazard ratios of over 4 for drug-related mortality by education level. And this supports previous studies showing alcohol and drug-related mortality that is and consumption to be higher in low socioeconomic groups. And the findings are evidence among which population groups that interventions should be targeted to reduce Australia's quite high mortality from alcohol and drug use. So a limitation of the study, I mentioned before, we couldn't analyse trends just because the linkage rates for the earlier 2011 census were somewhat lower, and there was concern about how consistent the results would be between the two time periods. But certainly these MADIP data are a very valuable resource for researchers and practitioners, and even more granular analysis of clusters of comorbidities can be conducted to improve understanding of inequalities in causes of death in Australia, for example, during COVID-19. So these are just some references, and I just would like to acknowledge the Australian Bureau of Statistics and the data custodians for making the data available in the MADIP. So thanks for your time, and I'm happy to take some questions.
Thank you very much, Tim, for this nice and insightful presentation using Australian data with a wide range of socioeconomic variables that you have and multiple causes of death. And well, this is particularly interesting to me as well. So there are a few questions in the chat. I can read them to you during 5 minutes, so then we give time for Paul to present, and we have some time at the end for a more general discussion. But maybe you can briefly answer some of these questions. For example, Marshall Brown was asking if you did consider socioeconomic status and diabetes and hypertension differences by age and sex.
Yeah, that's a good question. I haven't looked at that. I could easily look at it, and that's a good prompt for me to actually do that. I have found previously that in Australia that trends in death rates from diabetes and hypertension for younger age groups tend to be worse than for older age groups. So it would be interesting to see if socioeconomic inequalities are greater in the younger age groups than older age groups. I'm not sure. And yeah, again, I could look at it for males and females. I think there would be some similarities between males and females, but I think by age there may be some bigger differences, perhaps wider inequalities in the younger age groups. Certainly obesity levels in younger age groups are higher than in older age groups, or at the same age they are higher. And so when I say at the same age, sorry, when the cohort, sort of lifetime cohort obesity for younger age groups is higher than it is for the older age groups. So I think there could be some wider inequalities in the younger ages.
Okay, thanks, Tim. And also, Surikan Yadap was asking if the Cox model regression for cause-specific mortality, rate ratio or hazard ratio for drugs and alcohol were performed separately, or these were categories?
Yes, so I conducted a Cox regression for drug-related mortality, and then separately conducted a Cox regression for alcohol-related mortality. I didn't do it specifically for the drug and alcohol combined, because it is a fairly relatively low, it has a relatively low mortality rate, and so I had some issues just with running the Cox regression because of that, because of small numbers. But yeah, certainly, yeah, I did it separately for drug and separately for alcohol.
Okay, and so there are more questions in the chat, but maybe it's time to go through the next question. There is also another question from Ana Maria about differences in certifying across socioeconomic groups, but probably this question could be answered in the end, as I guess it will be there will be some share comments from both you and Paul. So I think that we can move to the next presentation. Thank you very much, Tim, and I will now give the floor to Paul Peters. Yeah. Whenever you are ready. Thanks.
Good morning. Thanks everyone for attending, and thank you very much for the invitation to come present today. Let me share my screen. Okay. Thank you, everyone. The title of my talk was Socioeconomic Variations in Multiple Cause Mortality, a census-linked approach, but you'll see that the subtitle has changed to a geographic approach, and I will say more on that later. So what I wanted to do today is essentially tell you two stories with some context. Like Tim, I'll provide a little bit of context of mortality and multiple cause mortality in Canada. Then I want to tell two stories that emerged from the data from this project that we're working on. One is looking at COVID-19 and multiple cause mortality by different socioeconomic categories. And then the second is one that may be unique in Canada and is emerging as an area of study for population scientists, simply because the numbers have increased dramatically in Canada for euthanasia or medical assistance in dying, as they call MAID here. But it's euthanasia is what we're talking about. This project is funded by Social Science and Humanities Research Council and is examining multiple cause mortality and socioeconomic correlates. So first, a little bit of context. In Canada, we see, a slow trend of the increasing numbers of deaths over the number of years, but very, very slow increase. We see the uptick, of course, in 2020 and 2021, where males have, as you can see, then in terms of the number of deaths, there's an increasing gap between males and females, where males are generally faring poorer, and the inequality and the differences between males and females is getting larger. If we translate that into age standardized mortality rates, though, I do like to always put the raw numbers out first, because it gives a little bit of context of what we're talking about in terms of numbers of deaths. We see, of course, lower age standardized mortality rates for females, and for males, with an uptick in the COVID era. So some of the gains and we saw leveling out sort of beyond 2016, but some of those improvements, of course, were shifted. And it's not, I do have to say, it's not just because of COVID-19. We do have although the numbers are smaller, we do also are dealing with drug and alcohol addiction, in particular an opioid epidemic in Canada that is dramatically affecting certain populations, which I won't get into in this presentation here. A little note on my graphics: I tend to use simplified graphics in here, so I'm not showing errors and things like that on confidence intervals. I am just showing the numbers. I try and make it a little bit try and simplify the presentation numbers. If we then look at mortality by income quintile, and this is by area-based income quintile, and we look at multiple census-based periods, 2001, 2006, 2011, We don't have the one for 2021, wasn't published, so they did publish the same thing for 2020. And looking at by income quintile, we do see the stepped differences we have between those in the first income or the lowest income quintile and the fifth income quintile or the highest income. This is relative, so this is based on area-based income, and it's the quintiles are calculated based on comparing within not the national level but within the regional level. And we do see that the difference in between the quintiles has reduced from in 2020 compared to other years, and even between 2011, where we saw a very similar pattern, 2001, 2006, 2011, each of those census periods, very similar sort of pattern in the differences between the upper and lower quintile, and we do see that we have a reduction in that in the most recent data that we have that I have available there. Looking at the data a little bit behind the scenes afterwards, the data that I'm using for this analysis that I'll present here comes from the Vital Statistics database, which is available in the Statistics Canada Research Data Centers, which is a program with the Tri-Council funding agencies, where we have a Statistics Canada Research Data Center on most major university campuses and can access individual level records. And Vital Statistics has long been part of this area. And it does include detailed geography. So we are able to access what we call 6-character postal codes, which provide quite a detailed location where we can then link some neighborhood measures of SES and assign those via postal code. Multiple cause of death files have also been available in the research data centers for about the last 6 years. And they're only available from 2000 to 2021. They're a little bit spotty in 2000, 2001. So I'd sort of like to say they're complete from 2002 onwards. And this links right to the Vital Statistics files, but they are a separate file, but they can be accessed in the same way. A little bit of the data that I wanted to present to you, and it would have really matched well with Tim's, unfortunately, is we do have an amazing program with of census-linked cohorts here, and it's available in the research data centers to all researchers, and it's at no cost to Canadian researchers as well. And that links the census, what we call the long form, so the sample, to vital statistics, followed for mortality, to hospitalization or discharge abstract databases, emergency room visits, incidence of cancer going back retrospectively, and annual place of residence, should be of residence, with the 6-character postal codes. Again, that goes back retrospectively, so we know where people have lived, and both in terms of follow-up, but also previously. Planned analysis, we plan to expand it, and indeed we have expanded it using the census cohorts. However, the vetting rules changed in September, where it moved from being able to treat it as a cohort to require it to be weighted using a weighting technique. But that changed in September, and so we weren't able to release our data for today. And we need, indeed, some of the stats that I'm presenting today aren't yet possible using the weighting techniques. So moving on to multiple causes of death, we see very similar numbers, and I do give a nod out to the most recent work from Karen Bishop and the Bishop et al. Articles, because this table is structured very similar, and one of my graphics is also structured very similar. And indeed, we followed a lot of the methodology in terms of coding of causes of death, and we did that. I did that very purposefully to try and be able to provide a comparison with a country with a similar population, similar geography, and although Canada, we're about 38 million, we still have we're relatively similar size. So we see, slow increase in the number of deaths. Mean number of causes hasn't changed significantly over time, although we have seen a reduction in the last year, and particularly an increase in the number of deaths with one cause recorded on the death certificate. And these numbers match up relatively closely to those in Australia. This does differ in terms of the number of causes that we see by different measures. So we can look at it by urban and rural, and we see in rural regions of Canada, in looking just around the time period surrounding the COVID-19, 2 years prior and 2 years after 2020 and 2021, we do see larger number of average causes in rural regions compared to urban regions in Canada. And we also see differences then in the mean number of causes by income quintile, where those the lowest income quintile, this is the area-based income quintile, do have a higher average number of causes, and those in the highest have a lower number of average causes. And then the difference doesn't really change very much. Again, I don't put in error bars. Some of this is due to error variation. But we do see, again, that reduction in the mean number of causes in 2020 and 2021, which is the most recent data available. We do see an uptick actually in 2011, a slight uptick, although the numbers, the scale was not very large, from 2011 to 2013. Prior to that, it's relatively stable. So I just didn't show that information. So if I look at some of the major causes of death, so this is 10 leading causes of death. I didn't include injury in there for males. Self-inflicted injury is a major cause of death. It's within the top 5. But as I was looking at wanted to look at underlying causes, the percent of if I look at total mentions, the percent where it's as an underlying cause versus contributing cause, and then overlaid on top of that, we see a line which is the standardized ratio of multiple to underlying causes. And again, this figure is a nod out to the Bishop et al. Very similar to in structure to what was done there. Apologies for the colors. Those sort of, if anyone has visual impairment, that might be pretty bad to see. But we see a change. The standardized ratio of mortality to underlying gives a age standardized essentially rate comparing the multiple causes to underlying causes, and we see a large difference. I hear I've ordered it based on the contribution from where these causes of death. It's the contribution to the overall number is mostly due to underlying cause compared to contributing cause. We see with ill-defined causes, and that's not and with diabetes, where it's more often a contributing cause compared to an underlying cause, and that's not necessarily surprising. But there's 2 things I wanted to sort of point out, and there's where I put these red arrows, and this is where my stories come in. Story number 1 of COVID-19, where it's coded most often, very, very often, as an underlying cause versus contributing cause. And then at the other end, where we have ill-defined causes, which are an increasingly large proportion of deaths in Canada, and in a country where ill-defined causes have traditionally been around 2% of deaths, or much less actually. They're relatively stable. This has seen a massive increase, and I already tipped my hat as to what this is due to. But the numbers are quite large. If I look then at the standardized ratio of mortality of multiple to underlying for sort of essentially the rank in the causes of death, the ICD coding for this in terms of how the categorization, we followed that done by the Bishop paper, again to be able to allow for comparability. between the results of those two projects. And we look at the SRMU, and we see relatively similar numbers between both males and females, with a few differences between the two, particularly for ill-defined causes, where we have a lower number, although they're both quite high, indicating that there's the majority of mentions are due to contributing causes for both, but it's lower for males, so more are as the underlying cause. So sort of that's the context. Then the first story that I'll get into here, looking at COVID-19 mortality. As in many countries, it had a differential impact on the population in Canada, although the impact was less in Canada than in other countries. But the multiple cause of death statistics provide additional information on the impact on mortality, and indeed we can see a few things that tell us a little bit about how we code deaths. So put it in the context, this is data that StatsCan has made available. And this is looking at estimated excess mortality. Again, I don't have error bars in it because I want to just make it look just to show the information. But the data in behind it actually has that in it. I just didn't display it. But looking at the essentially excess mortality by week in Canada from 2020 until currently. And we do see a cyclical nature, of course, and we can see the waves of COVID coming in, where we have significant numbers of deaths in excess mortality between those periods. And indeed, you can see this in other countries as well. We look at COVID-19 mortality in particular, and we look at where COVID-19 was the underlying cause of death. We see the contribution. So what were other conditions? If COVID-19 was an underlying cause, what were the most frequent contributing causes? We see neuropsychiatric conditions at 21%, cardiovascular at 25%, respiratory at 15% for when COVID-19 was an underlying cause. If COVID-19 was coded as a contributing cause, again, neuropsychiatric and cardiovascular, as well, respiratory shows up, but the dark green there is actually cancer, where cancer would show up as the underlying cause with COVID-19 as a contributing cause, which partially goes to the way in which cancer is coded, and how it is more how it is coded as the underlying cause versus contributing cause. Within the systems, coding systems. Look at COVID-19 deaths by age, comparing underlying cause and contributing cause. We do see a very similar pattern across the age groups, although there's slight differences between males and females. And part of the interesting thing on this is looking just simply at numbers is simply because of the age effect, where for 90 and more, there was significantly more deaths for females, and part of this is simply because there are more females in the underlying populations. This is looking at just death rate. This is just actually just death counts. By marital status, we do see differences as well, and particularly we see larger numbers with widowed. Again, not unexpected, given the population that was impacted. With more deaths for males who are married, and significantly more deaths for females who were widowed, and not much differences for single, divorced, or separated. If we look at percent of COVID deaths by the number of underlying causes, so we look at the number of causes, and so where there's only a single cause of death, but COVID would be that death, because we're looking at just COVID deaths here. And we look at by marital status, we really don't see much of a difference between, this is 2020 on one side, 2021 on the other. we don't see a huge difference across those with a higher percent here in 2021. Where we do begin to see a little bit of different stepwise gradient is we do see some changes when we begin to in 2021 compared to 2020 with those with more than one cause, where we see those who are in this case it's divorce. We do have a higher percent of those have 5 or more causes. And then by income quintile, males and females, we see the very stepwise pattern in terms of the gradient, the SES gradient for both males and females, where COVID is an underlying cause, with more deaths occurring in the lower income quintiles compared to the higher income quintiles. But where it's contributing cause, we don't necessarily, it's that stepwise pattern. We see a difference between males and females, certainly, where it's a contributing cause. And for males, it's more often a contributing cause than for females, which is relatively interesting. I do see lots of things in the chat, so hopefully I'll get to those afterwards. I can't see the chat while I'm presenting, unfortunately. Only one monitor. Then if I look for by income quintile, looking at 2020 and 2021, again, we don't see that same stepwise pattern for the number of underlying causes of death between those groups. Perhaps we see a little bit more of a gradient pattern here in 2020 between the lowest income and the highest income quintile, but we don't see that necessarily in 2021. And similarly in where it's looking at it as a single that. Indeed, if we do a simple Poisson regression and we look at then we do calculate the IRR of the mean number of contributing causes for COVID-19 deaths versus all deaths by neighborhood income quintile. We see that there's this is looking at the number of causes of deaths for higher income quintiles, comparing 2020 and 2021. What is a little bit interesting is that we see in 2020 we do see this income quintile, so that we see a lower number of causes of deaths for the higher income quintiles. So they would have a lower mean number of causes of death in that, but we don't see that in 2021. We see it beginning to become flat, so that there doesn't seem to be that difference in income quintile in terms of the average number of causes of death when individuals die of COVID, which is a little bit interesting and may relate to sort of the way the pandemic rolled out in Canada, whereas with other countries where the first hit was a lot of long-term care facilities, particularly, and a lot of individuals within the lower income groups. And if we look, what's an additional interesting thing about COVID-19, and this one I find relatively interesting, is so the differences between the SRMU, so again, the ratio of multiple to underlying causes hasn't changed significantly. If we see 2020 and 2021 for select provinces, and we see that there is a difference between provinces in whether COVID is recorded as an underlying versus contributing, although given the value, it's very, very close to 1, so it's almost always an underlying cause of death. 2021, it didn't, the actual rate didn't change a lot. However, it did significantly more so in Quebec, which points a little bit to that there's a change in coding practices of COVID-19, or potentially a change in coding practices that occurs differentially by province, where in Quebec, COVID-19 would be more often coded as a contributing cause compared to other provinces in Canada. Okay, story number 2, and this comes about really from looking at data, and it's rather than hypothesis driven. This is definitely data driven. And it really comes from this, looking at the percentage of deaths coded as ill-defined. Those are the codes that we call ill-defined there. And you can see that 2002 to 2014-15, it's stayed quite flat for males and females in terms of the percentage of all deaths coded as that. So we're just a little over 2% coded. Starting in 2016, we see a massive increase in the number of deaths coded as ill-defined. That really relates to two different things: Bill C-14 in 2016 and Bill C-7 in 2021. Bill C-14 legalized euthanasia through a process called MAID, which I'll explain a little bit in a minute. And in 2020, it expanded the eligibility significantly via Bill C-7, both brought through by the current Liberal government with support of the New Democratic Party. So it was a multi-party support for that. MAID, or medical assistance in dying, which is euthanasia, allows individuals who meet a set of eligibility criteria. They get assistance from medical practitioners to end their life. There's several different ways, and there are several different modes that can happen. And there are specific eligibility criteria under law. It's tracked from Health Canada. The data is available to be linked to vital statistics, and we're in the process of requesting that access. Eligibility was expanded in 2021 significantly, and this was based on a Supreme Court of Canada decision that said that limiting it to some of the limitations placed on who could do this or that. And the numbers have increased massively. So 1,018 in 2016, attributed to MAID, to over 10,000 in 2021. So you can see the massive increase. And so it's really becoming something which we can look at as a demographer. And so, how unfortunately, as of looking at just the vital statistics, we can only look at it this way unless we actually link it to the data, which I said we're in the process of doing. If we look over time, and this is, I like to say that this one I find actually a little bit scary. And this is looking at the percentage of deaths that are ill-defined by income quintiles, looking for males and females. And we see a little bit higher for the lowest income quintiles from 2002 to 2014-15. But within the margin of error. Again, I don't show the error bars on here. But starting in 2016, with the introduction of MAID, we see a large increase in the difference between those in the lowest income quintile and those in the highest income quintile areas, where we have deaths coded as ill-defined. And that's particularly for males compared to for females. But we see a large difference between the two. Indeed, where we have an over 2% difference between the lowest income quintile and that. So if we look at this by both sexes, so 2% of the difference between the lowest and highest income quintiles, if I just look at from 2011 to 2021. So what it's sort of saying is that the percentage of all deaths that are coded in ill-defined, that it's, I can't attribute which of those deaths are due to MAID, as the data is right now. As I said, I'm in the process of getting access to that. But if I look at the numbers of MAID and I plot those on there, and I look at the number of recorded deaths for the same years, 74% of all ill-defined causes of deaths could be attributable to MAID, simply because of the numbers. And it's most often coded as R98, is what it is. So it's an ill-defined cause of death that occurs in the home or outside a medical facility. And indeed, euthanasia is now 3.3% of all deaths in Canada. And I think we're very unique in the world in this. I think in terms of, and especially in terms of the numbers and the percentage of deaths. And it's becoming something that we can now look at as demographers and population scientists, whereas as something the numbers before were so low. And I think the difference between the highest and lowest income quintiles at the area-based level, and what we've seen is the area-based income quintiles in the past, when we look at mortality, it's attenuated, that the actual difference when we look at it at an individual level through a linked census administrative data is actually much larger. So that scares me a little bit when I think of that, and I think, okay, well, we're actually not seeing the real difference in income. And so there's a lot of ethical questions going on in Canada right now in about are some of these deaths simply due to poverty? And poverty is not an indicator for it, but the anecdotally, it sort of seems to be the case. So the two stories that we have, clearly there's differences in contributing cause statistics by SES. COVID-19 has been coded differentially as underlying or contributing, and that has changed over time, and it indeed is changing and doesn't change equally across different provinces. And I think the bigger story, and I say that this is data driven and that these numbers are, I haven't seen these elsewhere. It's now a major cause of death in Canada. And so there are large significant differences by income quintile, and it's not actually ill-defined. So they're coded as ill-defined in vital stats, but it's not actually ill-defined. We know exactly what it is. But it's only a matter of once we actually link the data into vital statistics and into a census-linked data set that we can actually attribute those ill-defined causes to what they are. But given the correlation between those two, I think the story is relatively clear. So thank you. Acknowledge the work of my co-authors, in particular Michelle Lopez Barrios, was a postdoc who worked with me and did a lot of the work with the COVID numbers. I'm happy to take any questions from the chat, and I'll stop my sharing here.
Yeah, thank you, Paul, for this interesting presentation. There are actually some questions in the chat, and thank you to all the participants for writing some questions. And so there are a couple of, or at least I would like to ask you a couple of comments or questions that have been written here. So Karen Bishop was has written a comment on the high standardized rate of multiple to underlying ill-defined causes of death that could be expected using all causes or multiple causes of death, as these conditions are often consequential of the underlying cause.
Yes.
So,
yeah. I mean, yes, I agree with that statement. I sort of was pulling out, and in a way, I sort of was pulling out those. What are they? I pulled out the ill-defined because it's not surprising that the way the SRMU would look, but then putting it in the context of that it's not actually an ill-defined cause of death. And I know very little about how it's coded, because we don't identify those deaths on the death certificates, and we can't isolate those currently in the vital stats as researchers. So I don't know if they put the if ill-defined is put as the underlying condition, what they actually put in terms of contributing conditions, and that's sort of something that I'd be really interested in. So that do they actually put the reasons as to why an individual chose to end their life?
okay, thanks, Paul. And there are also a couple of questions regarding COVID mortality in Quebec. And you just showed that COVID mortality, I mean, that contributory cause, COVID as a contributory cause is higher in Quebec than in the other regions that you have analyzed. And Doris Duran is asking whether you know a bit more why this is happening, and some other people has pointed out whether this could be influenced by population density in Quebec.
Yeah, I don't know if it would. I don't know if it, I mean, especially because if you look at it compared to Ontario, two similar population sizes, both have large population densities, indeed probably a greater density, and if you look at the GTA overall. So I think you could I don't know if you could definitely say that. But in terms of, there's another sort of thought here about where COVID as a contributing cause more frequently. I don't know why it would have it more frequently in terms of percentages of the deaths, and in terms of the SRMU, in terms of what we sort of see from that number. But we do, I mean, the health, because health systems are provincial, and Quebec in particular might be an outlier, partially because it's the only French language province. So there may be differential changes in information into coding practices that may be different there than elsewhere. We know that it's different between countries. So it would also make sense that it would be different between provinces.
Okay, and are the death certificates also different physically between the regions? Because I mean, if you compare European countries, death certificates have some kind of small but important differences that could also lead to some differences in reporting.
Yeah, you're right, exactly. And then of course the data is then translated into into just the vital stats database in StatCan. So you're right, the death certificates have important differences, but we don't necessarily, at the data end, we don't see it. They're all the same. 1 through 20 causes that they put on there.
Yeah. So there is one more question from Nehama Goldberger. Don't most euthanasia deaths have some other underlying cause which leads to the desire for euthanasia, which should be written on the death certificate?
Yeah, and this is the question I have. Is that we don't know, because we don't know which of these R98 deaths, because that's put as it's clearly that's what the deaths are. I mean, we're not going to see any other. There's no other reason why we would have this massive increase in ill-defined causes of death. Then those are the main deaths. It tracks exactly. But I don't know which of those deaths are due to euthanasia or not. So I can't tell which deaths, what's written on the death certificate for those ones. The only way I can do that is they do have a linked data set, which we can get in the research data centers. I can link that then to the vital stats files, and it will actually tell me which of those ones are due to euthanasia, and we could then look at it for that one, and we can see exactly what is coded. And I know that there's additional information that would be available on that. Partially, I'm a little bit in a way as looking at analysis. It's really messy to be able to have this coded and still defined in terms of looking at it, and in terms of because we're the numbers are so much larger in Canada than elsewhere. I don't think anywhere else has those larger numbers. When I look at it from a coding practices, it doesn't, the face value, unless someone can tell me otherwise, logically I don't see why that's where it should be coded. Right. There's other areas where it could be coded. In particular, there could be an additional category under legal intervention. Where legal intervention right now is largely firearms discharge, things like that. But there could be another place in the ICD where that should actually sit better, other than just, especially if we know what it's from. It's not actually ill-defined.
Yeah.
Right. So, and I think that's an important thing, because otherwise, as researchers, we can't track it, and we can't ask questions about it, and we can't look at things like that there is a large differential between income quintiles, where it's the poor in the population the poorest in the population who may be choosing to end their life, versus those in the higher income regions, which is explicitly not one of the criteria that should be taken into account.
Yeah. So. And now let's open the debate for more general questions, and I guess we can start from the question that was formulated before by Ana Maria Nogales, and relating to what we have been discussing now with Paul on the kind of potential differences in certifying practices across regions in this case, or in the case of Canada, or across socioeconomic status in the case of Australia. I'm not sure if you have some evidence or knowledge on whether there could be some differences to that regard, or what could be done, what could we do as researchers to try to minimize these potential differences across social groups or across regions. I don't know, maybe Tim, you want to comment on that?
Yeah, it's a good question. I'm not aware that there are terribly strong differences in by socioeconomic status or by region. Like the decol CVD conditions I was reporting on, the highest rates for that are actually in fairly remote areas amongst Indigenous communities. So in those communities where there's high levels of high blood pressure and diabetes and so forth, we are finding that they are reported on the death certificate. So so the sort of at face value, there doesn't seem to be much of a difference in reporting. I think for other causes of death, there may be though. Dementia is one where I have done a separate analysis myself, and dementia is commonly reported with other causes of death, so cardiovascular disease. And I have done some analysis that did show that dementia was less likely to be reported in more remote, more rural areas. Why that's the case, maybe it's to do with diagnosis or the interaction, the extent to which people interact with the health system. So I think for some conditions, it is probably the case that there are different reporting practices, whether that's due to simply knowing whether someone had a condition or not. But yeah, I think there's definitely scope for looking at it, and that's where multiple causes of death can be. A multiple cause of death analysis can be useful, because if you have some conditions which perhaps are not reported differently between regions, if you use that as your baseline, and then if you can be fairly sure that there's an expected percentage of those deaths with that condition that should also have another condition, then you can analyze the other condition between the different regions.
I'll just sort of echo Tim in that I think that it's very similar in Canada. I did used to work for StatCan. I worked for StatCan for 6 years. And when the first multiple cause of death file was first brought online, made available, it was always captured, but it wasn't made available for researchers. We did look at that, and we tried to confront the data by a whole bunch of different things, right? Looking at, was there any differences that we could see? And there wasn't really very little, but urban rural was one, particularly remote, that there potentially were different coding practices for certain conditions in remote communities, for likely similar, from what Tim says, like similar populations in some respects in terms of, the population distribution, particularly with geography.
And Viviana HG is wondering whether socioeconomic differences you observe, I guess this is the question for Tim, whether it could be partly explained by the place of death for the different socioeconomic groups. I guess that there is some research, at least in the UK, showing that individuals who die in hospital tend to have a higher number of diseases reported to the death certificate as compared to individuals who die at home or elsewhere. So I don't know if this could be kind of a way to move forward and to try to somehow standardize for these potential differences.
Yeah, unfortunately, I didn't mention that we only have one of the years of data. All the I think we have multiple cause of death data from 2007 onwards. Only in 2019, for some reason, we have place of death. Every other year, we don't have place of death. So it's quite frustrating that is the case. I could have a look to see the likelihood of reporting by place of death for each of these conditions. But I have seen from American data that during COVID, that those who died in hospital were far more likely to have COVID reported than those who died outside of hospital. And that's, even controlling for similar levels of for what other conditions were reported. I mean, that's obviously one disease in particular, but I haven't had the opportunity to look at that analysis for Australia. But yeah, that it could well be the case that there are differences by place of death.
Yeah, I haven't looked at it either, especially because we have for a lot of years it's not that data field isn't complete for all provinces in Canada. So it's not one that I've looked at. There's sort of, for some provinces it's not complete for some years, and some provinces it is complete for other years. So it's not a very reliable field, unfortunately.
Yes, and then also I think this skills was asking, comparing males and females, is the socioeconomic gap generally larger among males? And I guess that she's referring to COVID mortality based on her previous comment.
Sorry, I'm trying to find the question here.
Yeah, it's the last one here in the chat.
Yes, I mean, for the numbers that I saw, it is, and it is based on the cohort, the census linked data, but also then the area based stuff, so that the socioeconomic gap is larger among males than for females. That sort of seems to track based on the other research that I've done too before, looking at even if we look at Inuit, First Nations, and Métis, so Aboriginal populations, there the gap is larger for males than for females. And Tim, I would imagine for, as you sort of seen, for those conditions.
Certainly, yeah, drug related mortalities, certainly there's a wider gap for males and females, but actually obesity, it's the other way around. It's slightly higher for females than males. Why that's the case, I don't quite know. Maybe perhaps obesity is a bit more common amongst men across socioeconomic groups. I'm not aware of the reasons behind that, but it's an interesting finding from the analysis I did.
Yeah.
Thanks. And then Jeremy,
sorry, go ahead.
No, go ahead.
I was just say I saw one come up about age standardizing the rates. Yeah, that's sort of the next sort of one of the steps, is I didn't produce the age standardized rates, but if you look at the age standardized rates that are published, you still do see a huge increase, and it is the older population generally, in terms of numbers. So it would track with that, but the raw numbers to me are very striking.
Okay, thanks. I don't see more questions in the chat, but maybe I can ask a question to Tim. So I was wondering about, so you presented inequalities based on individual indicators like education and area level indicators. Could you say a bit more about the area level indicators that you have provided? Because I was a bit surprised to see that inequalities by area level, by areas, let's say, were almost all the times as large as inequalities based on individual metrics, and this was a bit surprising to me. But then you were mentioning that these areas were quite small. So yeah, if you could say something else, thanks.
Sure. Yeah. So the Australian Bureau of Statistics, they have a few different indices that are used to measure socioeconomic status, and so this one is the index of relative advantage and disadvantage. So it's an index that is they calculate based on a whole range of variables. I can't remember how many variables there are, but it's measured at every small area in the country. So yeah, on average about 400 people live in each small area. So I guess in some ways, because it's an index combining not only would be education and income and maybe occupation and some other characteristics, that it's perhaps even like if we were to measure each individual using this index, I would expect we would have wider inequalities than for, say, education than for income, simply because we're putting all the, they're combining the different all the different characteristics. And so while education may not be perfect, as a measure of socio-economic inequalities, and income may not be perfect, but if you develop an index combining them all, then you really are getting quite close to the extremities of the socio-economic advantage and disadvantage. And so so because of that, even though it is aggregated at a small area level, perhaps it is giving us inequalities of mortality that are similar to individual measures of education or household measures of income. So yeah, I'm not aware of that index being available at the individual level, but that's something I could perhaps look at, is doing an individual socioeconomic index and seeing the differences, because I'd imagine they would be probably larger than what I've shown for educational household income.
Yeah, thanks, Tim. That could be interesting. So it's now 2:30 here in Europe. I think it's time to give the floor to Aline, that will probably close the floor. Thank you to Paul and Tim, the speakers, and to all the participants. And I give the floor to Aline. Thanks.
Okay, so thank you, Sergio. Just
Thank you, everyone.
to close this session. So thank you for your very active participation in this webinar. Of course, we will keep you informed about the activities of the panel, and in the reverse direction, please do not hesitate to inform us about your activities, about your publications, conference, etc. on the topic of this panel, so that we can share it with the members of the panel. So thank you. Have a nice day. Night, I don't know. And see you soon. Bye-bye.
Yeah, thank you.